Good morning. Thank you, Sue, so much for putting this conference together. What a tall order to follow Dr. Sheth. And I just want to, thank him on behalf of all of us that work on this topic, his relentless advocacy, and he has been such a champion for ICH research and having greater attention be paid to this. So I really, really appreciate your advocacy. And thank you to all of you for coming and, really valuing the potential that we have to make a big difference in patients' lives by paying greater attention to intracerebral hemorrhage and, of course, the acute management of this. My name is Regina Royan. I'm an emergency medicine physician at the University of Michigan. And today I'm going to talk about the recognition and early emergency department management of ICH. I have no disclosures. So some objectives for our talk include recognizing the clinical features of ICH versus ischemic stroke, reviewing some diagnostic approaches, discussing acute treatment strategies that occur in the emergency department, including blood pressure management and anticoagulation reversal. There will be a wonderful talk a bit later by our neurosurgical colleagues on acute surgical interventions, which I will not touch on here, but of course this is a very promising area for improving outcomes in ICH. Along the way, I'm going to highlight some of the AHA and ASA guidelines, which you all have on your tables, which is so convenient, and some of the landmark trials that have brought us to where we are today. I want to start with a patient case, and I encourage all of you, of course, I'm anticipating that most of you here are clinicians or have had a clinical role in the past, maybe have transitioned to quality improvement. Really think back to those patients that you have had that have had ICH and what a tremendous impact that you might be able to have in their course of care or future patients as we go along. The patients that I'm going to share in this presentation are not real patients, but they are inspired by patients that I have seen in the emergency department. And so our first one starts with a triage note. 10 a.m., a 67-year-old female woke up with a headache and felt off all morning. She reported feeling dizzy, too nauseous to eat breakfast. Her fast stroke screen at triage was negative. The patient was sitting in a wheelchair. She was triaged as an ESI level 3, which if you aren't familiar with, this is an emergency severity index. Every patient that checks into an emergency department is assigned a number between 1 and 5 of how sick you are, what your level of acuity is. She got assigned a level 3 with a chief complaint of dizziness, and she went back to the waiting room. Around 3 p.m., she was placed in a hallway. And I will mention that at pretty much every academic center right now across the country, if you are assigned an ESI of level 3, that pretty much buys you a 4 to 6 to 8 hour wait in a waiting room. So around 3 p.m., she was placed back in a hallway bed, and around 3:15, she had her first physician assessment. At this time, she was noted to have some dysmetria, ataxia, and vertigo, and a stroke code was called at 3:20 p.m. As you might suspect, this patient ended up having a cerebellar ICH. Approximately 10% of the nearly 800,000 strokes that happen in the US each year are ICH. And one of the most important things I want you to take away from this talk is to have a high index of suspicion and obtain prompt imaging when these patients present. In our last case, this patient was screened for a stroke, but she was fast negative. Stroke scales historically have been designed primarily to identify stroke in general, and in many cases to differentiate between stroke and stroke mimics, not to differentiate between ischemic stroke and hemorrhagic stroke. However, some scales and clinical features can suggest a higher probability of ICH. For example, higher NIHSS is often associated with hemorrhagic stroke, but this is, again, not specific. In this table, I highlight some of the more common stroke scales, the Cincinnati pre-hospital scale, which is the most commonly used pre-hospital scale in the country, the Los Angeles pre-hospital stroke screen, FAST and BFAST, as well as NIHSS. None of the existing stroke scales alone can reliably distinguish between ICH and ischemic stroke. So how can you have a high index of suspicion for ICH when the existing stroke scales don't help us differentiate between stroke subtypes? This chart is adapted from an excellent review in the New England Journal of Medicine that was published by Dr. Sheth in 2022. And some clinical clues that can help us keep in mind for ICH are the progression over minutes rather than an instantaneous deficit, headache, which is present present in up to 50% of cases, more common than ischemic stroke. Nausea and vomiting, which can be due to increased intracranial pressure from a bleed. Decreased level of consciousness is more common in ICH. It can be earlier and more profound, especially with larger hematomas and brainstem involvement. And then seizures are present in 10 to 19%. Some takeaway points on early recognition. No pre-hospital or commonly used stroke scale can reliably distinguish between ICH and ischemic stroke. The key clinical features included decline in consciousness, severe headache, and vomiting. And the 2022 AHA guidelines recommend the use of a pre-hospital stroke scale for first responders and emergency providers to identify potential undifferentiated stroke patients. I'm going to move on to imaging now. Non-contrast head CT is the gold standard for diagnosing a hemorrhagic stroke, as you might expect. The sensitivity is nearly 100% within the first 24 to 48 hours. It's quick, accessible, and excellent at identifying bleed size and location. MRI is more sensitive for small bleeds and subacute bleeds, but maybe less practical in the emergency context as of now. The 2022 guidelines recommend that CT be obtained immediately, and then serial head CTs can also be useful for evaluating hematoma expansion. An underlying macrovascular cause, like an AVM, a dural arterial venous fistula, cavernoma, or cerebral venous thrombosis, these are all causes that can be present in 1 to 4 or 1 to 7, 1 out of every 7 patients, depending on the age category. Several studies have also identified a spot sign as a possible prognostic indicator for hematoma expansion. Thus, you can consider also obtaining a CTA or CT venography to identify underlying vascular causes. I'm going to shift gears now into acute treatment by highlighting a second patient case. This is a 55-year-old male with a history of poorly controlled hypertension who presents with an acute onset of left-sided numbness and weakness. It sounds very similar to the case we heard in the video. Presenting blood pressure was 230/110. Often ICH, secondary to uncontrolled hypertension, can present in the deep structures of the brain, such as the basal ganglia. I didn't see this video before, but perfect example. And they exhibit mass effect on the surrounding structures. So something like this is a common presentation for ICH. So how do we manage blood pressure in the emergency department? First, I'm going to highlight some of the landmark trials and studies that have contributed to the best practices that we have now. A big question in ICH treatment and research is, does the rapid lowering of blood pressure improve the outcomes of patients with ICH? In the INTERACT 2 trial, patients were randomized to receive intensive blood pressure lowering to less than 140 within 1 hour versus less than 180. And they found that intensive blood pressure lowering did not result in a significant reduction in the rate of the primary outcome, which was death or severe disability. However, an ordinal analysis of the MRS, meaning we looked at each level of the MRS, indicated improved functional outcomes. ATAC 2 looked at patients with ICH with a bleed size of less than 60 cc's and a GCS of greater than 5, and they gave IV nicardipine to control blood pressure. And they were looking at, does lowering the SBP to a target of 110 to 139 improve rates of death or disability versus a target of 140 to 179. The intensive blood pressure control did not result in a lower rate of death or disability than the standard targets. And there was no significant between-group difference in the ordinal distribution of the MRS score at 3 months. There was also an increased incidence of adverse renal events in the intensive blood pressure lowering group, and this will come back when we look at the 2022 guidelines. In a post hoc analysis of the ATAC 2 trial, in a subgroup of the ICH patients with elevated blood pressure that were given IV nicardipine within 2 hours of onset of symptoms, intensive blood pressure reduction was associated with reduced hematoma growth and improved functional outcomes. Next is the INTERACT-3 trial, which evaluated the effect of a bundle of care, which included early intensive blood pressure lowering to less than 140, as well as glucose control, treatment of fever, and rapid warfarin reversal for ICH patients that presented within 6 hours of symptom onset. The implementation of this care bundle resulted in lower odds of a poor functional outcome and fewer adverse serious events. Next, we have the INTERACT-4 trial. You can see a trend here. The INTERACT-4 trial involved pre-hospital reduction of blood pressure for undifferentiated stroke patients. Again, we come back to the fact that we can't reliably in the pre-hospital space or in the emergency department identify who has an ICH or who has an ischemic stroke. And so this this trial looked at undifferentiated stroke patients. And pre-hospital blood pressure reduction did not improve functional outcomes in undifferentiated stroke. However, 46.5% of these patients ultimately had a hemorrhagic stroke. When you look at just those patients that had hemorrhagic stroke, there was a lower odds of poor functional outcome among those patients, but a higher odd of poor functional outcomes in patients with ischemic stroke. So if there was a way for us to identify ischemic stroke early, we might be able to change that story. In a pooled analysis of all 4 INTERACT trials, the intensive blood pressure lowering initiated within several hours of the ICH onset was safe and improved functional recovery without a clear effect on hematoma growth. The greatest benefits for both of these outcomes occurred when treatment was initiated within 3 hours of symptom onset. You can see that this is a common theme. Earlier intervention is better, including for ischemic stroke, or including ICH, I'm sorry. So in summary, most patients with acute ICH presented with elevated blood pressure, and elevated blood pressure and presentation is associated with greater hematoma expansion, neurodeficits, death, and dependency. Thus, it's intuitive for us to treat high blood pressure during the acute phase of ICH. The guidelines outline that the primary recommendation is that lowering SBP to a target of 130 to 140 is safe and may be reasonable to improve functional outcomes in patients that present with a blood pressure of 150 to 220. Initiating this treatment as soon as possible with careful titration to ensure continuous and smooth and sustained blood pressure control are recommended. And finally, acute lowering of the SBP to less than 130 is potentially harmful and should be avoided. So we want to do it fast, we want to do it smoothly and with careful titration, but we don't want to overshoot. Moving on to our next case, this is a 74-year-old male with a history of AFib on Eliquis who presented with sudden onset of headache followed by left arm weakness. After arrival, the patient was noted to have right-sided gaze preference, and 20 minutes later noted to not be able to move the left arm at all. A primary concern with anticoagulation-associated ICH is hematoma expansion, leading to progressive neurodeficits. So next I'm going to touch on some of the recent studies on anticoagulation reversal, including INCH, ANEXA-4, ANEXA-I, and the large cohort study using Get With The Guidelines data. First is the INCH trial, which had patients with vitamin K-associated ICH that were given 4-factor PCC versus FFP within 1 hour after their CT scan. And there was no significant difference was observed in functional outcomes, although the study wasn't powered for this. The study was stopped early by the Data Safety Monitoring Board because of concerns in the FFP group, who had a higher rate of hematoma expansion. There was no difference in the severe side effects or thromboembolic events. Infusions of PCC were significantly faster than the FFP group, and for any clinicians there, the volume of these two treatment modalities is very different. PCC is a very small amount of fluid volume, where FFP, think of like hanging a unit of blood. It takes time to infuse. In ANEXA-4, patients with major bleeding anywhere in the body, not just the brain, within 18 hours of their last dose of a factor Xa inhibitor were given andexanet reversal agent. Andexanet alpha significantly reduced the anti-factor Xa activity. The reduction in anti-factor Xa activity was not predictive of hemostatic efficacy overall, but was modestly predictive in patients with ICH. And then finally, ANNEX-I tested the efficacy and safety of andexanet in limiting the expansion of hematoma volume in patients with ICH. The hemostatic efficacy occurred more often in the treatment group than the usual care group. However, there were higher rates of thrombotic events in the intervention group. Next, we wondered, does the timeliness of reversal matter? In a large cohort study that was actually conducted by Dr. Sheth and colleagues using Get With the Guidelines stroke data from 2015 to 2021, a door-to-treatment time of 60 minutes or less was associated with lower mortality and fewer hospice transfers. And this is an area that we're really excited about because with the addition of the new hemorrhagic stroke data layer, we are gathering a lot more information about timeliness of treatment and where this treatment occurs for hemorrhagic stroke patients. So I anticipate that we'll have a lot more real-world data coming down the pipeline in the next few years, which is really exciting. The 2022 guidelines emphasize that anticoagulation should be discontinued immediately and rapid reversal of anticoagulation should be performed as soon as possible after the diagnosis of ICH to improve survival. We have strong evidence that reversal in vitamin K antagonists should be done with PCC as well as vitamin K, and moderate levels of evidence for reversal agents for heparin, dabigatran, and direct oral anticoagulants. In summary, time is brain in ICH too. It's important to keep a high index of suspicion for ICH that may not be as easily recognized as ischemic stroke by pre-hospital or triage providers. It's important to obtain rapid imaging to diagnose ICH, and control of blood pressure early with smooth titration and avoiding overcorrection is essential. And finally, initiating into anticoagulation reversal for eligible patients is also important. Further reading, I've listed the 2022 HA's guidelines, which you all have on your tables, which is wonderful. And there is also an excellent review article by Dr. Sheth that is in the New England Journal of Medicine that gives a great summary of where we are, where we've been, and acute treatments for ICH. Thank you, and I'm happy to take any questions.
Please go ahead and head over to the microphones.
So another ambiguous sort of a question in terms of patients who've had ischemic stroke, very large, and end up having a hemorrhage in the stroke bed.
Yeah.
How do you balance the guidelines suggesting lowered blood pressure for hematoma expansion versus allowing for permissive hypertension to rescue the penumbra? And how is that data captured? Because Get With the Guidelines can look at one or the other and find you non-compliant with either.
That's a great question. I think most of the Get With the Guidelines studies that have looked at this to date purposefully exclude hemorrhagic transformation of ischemic stroke in their analysis, so they're not really in this data that I was talking about generalizable. Of course, that's a really nuanced decision, and I think it also has to, you really have to make a judgment call as to how much of that brain do you think is already gone. Like how much, do you have a large cord that's not able to be rescued by permissive hypertension? I think the talk after me is one of our neuro ICU attendings, and I think that is perhaps in their talk, but that's a great question. Unfortunately, we don't have a good, we haven't included that in some of the existing Get With the Guidelines studies, but it would be really interesting to look at the hemorrhagic transformation of ischemic stroke.
I have a question, Dr. Royan. As part of our work in stroke system of care, we know that feedback loop to EMS and our transferring hospitals is critical. That has pretty much been hardwired with our acute ischemic stroke patients. Has there been any thought within your organization of how to operationalize that process, or is that something that any of you have been considering or maybe have implemented?
That's a really good question. I'm not sure of anything that is formalized. I think it is really case dependent and largely driven in part by our neurosurgical colleagues and our neuro-ICU colleagues, because of course, if there is a decision point of whether a patient that is at a referring hospital needs surgery, then we move heaven and earth to get that patient here to the mothership to get that intervention. Whether if they are not a surgical candidate, I think the default kind of position is to keep patients, in their local community with their support systems if possible. So it's a really patient by patient. I don't think we have a clear protocol, at least at our institution.
Thank you for that. I think as we begin to socialize those time-critical interventions for our ICH patients, as you've seen in Get With The Guidelines, if you do collect that time to blood pressure control, time to anticoagulation, that we start thinking about, that feedback of that transfer process, how our patients arrive to us, so we can start breaking down those length of time and how to improve and have those opportunities noted.
Excellent. Hi, great presentation. Paul Weiler, System Stroke Program Director for Advocate Illinois and Wisconsin divisions. My question is more around the andexanet alpha and the trials that you were sharing, and I think what's really challenging is, first of all, to do any kind of global implementation. It becomes cost prohibitive, keeping it at small rural sites. And then we talk about some of the potential complications with the thrombotic events. And just would love to hear some of your thoughts about whether you started using andexanet alpha at your organization, or some of the ways that we can get better evaluation for how we best do more standard care across the nation. So.
Yeah, that's a really good point. Of course, I work at University of Michigan now, but before this, I worked in a community hospital. I worked at Lake Forest, which is sort of near where you are. And this is definitely a consideration. The cost of this drug is high. It's not insignificant. And smaller hospitals may not feel that it's practical to have on hand. I think the evidence that we have right now is that it helps reduce hematoma expansion. Whether we think that ultimately translates to improved functional outcomes, these studies were not powered to help us specifically answer that question, but we know it does reduce hematoma expansion. I think we're going to have to balance that with some of the new surgical techniques that also can help us evacuate hematomas. But with the evidence that we have right now, it seems like patients that are at risk for this should be getting this drug.
Hi, Kelly Vogel, Comprehensive Stroke Program Coordinator at Froedtert Hospital. In your first example of the patient that initially had that ESI of 3, with these patients that present and don't have any obvious stroke symptoms, do you have any suggestions or recommendations for education to give to some of those triage nurses just to bring awareness to these patients that don't present acutely?
Yeah, that's a great question. And this is like one of my pet peeves, pet issues. So this patient, I made a point of saying that this patient presented in a wheelchair. And many of you may use FAST as your ED or pre-hospital stroke screen. The B-FAST, which includes balance and eyes, helps increase your sensitivity for detecting a stroke. And in this particular patient, nobody made her get up from her wheelchair. And I wonder if they would notice that she had truncal ataxia, had poor balance. We will never know because she may not have when she walked in the door. It's really hard. I don't know if there are any other physicians in the room or emergency providers, but there is a boarding crisis across the nation, and unfortunately these patients don't get reevaluated in the same way that they would if they were coming right back to a bed. And so particularly with hemorrhagic stroke, having multiple time points where we're evaluating and have they developed any new symptoms from when they walked in the door is really important to be able to detect. And unfortunately, patients like this that sit in a waiting room for a long time don't get that interval kind of evaluation to see if their symptoms are progressing. Yeah, she definitely would have gotten vitals. I don't recall what they were.
Hey, my name is Sarah Andrews. I'm the stroke program manager for Ascension, Texas, and I have more of a thought out loud than a question. We're only an hour into this summit, and already I feel so inspired and also optimistically cautious that we're doing the right thing. And I mean that personally within our organization. And I think I'm just so grateful for the conversation we're having, the mentor site conversations that we have. And they should not be underestimated, because there was a question after Dr. Sheth's presentation also, which was what can we do right now, at our hospital right now? And sometimes when I think about the big picture, we become overwhelmed and we become paralyzed. And it's actually, we're only 2 speakers in, and already I'm like, yes, our organization, we are doing the right thing for the patient. We have spent years within our system of care operating MR for acute stroke. Our treatment rates and are through the roof. And we have translated that sense of urgency and moving everybody else out of the way for our stroke patient. And now we're having to pivot. Okay, so MR for acute stroke in our organization takes about 6 minutes. But now we're having to pivot because we've inserted ICH into our acute stroke process. We did not develop a new protocol for ICH. That is our acute stroke. Doesn't matter what flavor stroke, but that's part of our acute stroke protocol. And so all of these conversations, and I'm so inspired that maybe we are doing the right thing. So I would echo what Dr. Sheth has said and what you are saying. You can take something right now and implement it. Progress, not perfection. And the brain power in this room is awesome. And I'm humbled to be sat here listening to this awesome conversation, and it matters. We can make a difference right now before the end of business. It's awesome. I've already posted so much to our group at home, so it's brilliant, and thank you so much. I feel like we're doing the right thing today in this moment, so thank you.
Thank you, Sarah.
Thank you for that, and I totally agree with you, and thank you to all of the sites that are participating in the ICH data layer, because having this real-world data is so valuable for us to see how time to treatment and which treatment patients are getting. All of these things are going to be uncovered in the coming years as we gather this data. So thank you so much for participating in your effort. That seems like a great place to pause.
Thank you so much, Dr. Royan. That was wonderful.